Welcome everyone to our Army education series. We do these webinars, try to do about every 6 weeks, and we have great pleasure of having Dr. Bert Mandelbaum join us today. I'll just do a quick introduction to him before we turn the time over to his lecture. Dr. Mandelbaum is one of the world's foremost experts in the treating of orthopedic conditions, especially those related to the knee. He practices and serves and co-chairs at the medical affairs for Cedars-Sinai in Los Angeles, and spends most of his time there helping patients. Due to his vast experience, he is one of the world's most prestigious athletic orthopedic surgeons, serves as the Associate Chief Medical Officer for Major League Soccer, Medical Director for FIFA at the Medical Center of Excellence in Santa Monica, and is co-director for the U.S. Olympic Committee National Medical Center of Excellence, where he sits as a medical network advisory group. He's also a pioneer in many orthobiologic techniques and the co-founder and former co-chairman of the Biologic Association. Anyway, great pleasure to have Dr. Mandelbaum today, and without further ado, we'll turn the time over to him.
Great. I'm going to share my screen if I may.
And sorry, Dr. Mandelbaum, real quick, for those that have questions throughout the lecture, please go ahead and type them into the Q&A section, and we'll have time at the end. We'll read those questions off and answer them at the end. So go ahead, as questions arise, just type them into your Q&A section.
Great. Well, good afternoon, everybody, and hopefully everybody is going to enjoy their lunch during this webinar. And Dan, are we seeing my slides at this point?
Yep, they look great.
Okay. So my topic for today is really to talk about orthobiologics in the athlete. And I really want to deal with fact, fiction, and fantasy to help you understand how we use things, why we use things, and when we use things going forward. Now, when it comes to athletes, it's really a trilogy. We're always about prevention, performance, and injury care when we're talking about our athlete population. And today, when we talk about specifically orthobiologics, we're going to talk about concepts, techniques, and technologies. And again, these trilogies are really important to understand where we go from here. Now, let's tell a story about orthobiologics with respect to athletes. And again, I tell this story, basically a man came to me who had some arthritis. He paid $18,000 to a doctor in Mexico, and he was going to inject stem cells from a Russian embryo, and he wanted to know what I think. Raising the question of fact, fiction, and necessity, I really say that perhaps that may be the best thing to do at this point in time. And again, everything's about stem cells and marketing, and it's about new cheeks and new breasts. But in reality, when it comes to the athlete population, we have to know what's real, what's fact, what's fiction, and what's necessity. And again, this concept of hope and knowledge, and the gap between hope and knowledge is critical for us, especially when we're team physicians. But this story goes way back to Ben Franklin in 1894, when as ambassador to France, he would really manage this whole approach in terms of understanding how to verify, validate the scientific process. He was the one that did the double-blind technique, because at that time, this fellow here, Franz Anton Mesmer, was mesmerizing patients, exploiting the gap between hope and knowledge, and developing evidence-based approaches, helped us understand what's right and what's wrong, especially in what we're doing. If we look at our whole world of PRP and other biologics, it was Kobe Bryant in 2011 with respect to athletes 11 years ago that we really began to think about this in terms of our athlete population. And things spread quickly to everybody. Once Kobe had it, we then moved along and we felt it was like this. And every athlete said, I'll have what she's having. And that's really what led to the tremendous explosion of where we are today. And hence, understanding the differential between fact, fiction, and necessity going forward. But if we look at the athlete population, regardless of soccer, football, baseball, basketball, it comes down to big three for the burden of athletic injuries: hamstring strains, ACL tears, and down over here, osteoarthritis. So there we have it. All of sports, all countries, all over the world, it's about the big three. So how do we manage players' knees with respect to hamstring strains? We're going to talk about tendon issues, ligament issues, meniscus, and cartilage going forward. And what we're going to learn about, most importantly, is how we approach this, when we recommend which technologies we caution, and which ones at this time we do not recommend going forward. And that's really the purpose of today. So let's look at this family of orthobiologics that we have. And if we look at the family of orthobiologics, it goes from all the way from corticosteroids down to WNT pathway inhibitors, glucosamine, HA, PRP, cytokine modulation, stem cell procedures, exosomes, alpha-2 macroglobulin, amniotic fluid, estrogens, M2 macrophages, and as we said, the WNT pathway inhibitors in terms of management. So how do we choose and what do we do and how do we do it? What's the ideal combination are the questions we're going to answer this afternoon. So let's start with simple things like patellar tendinopathy. Evidence-based, 19 studies, 4 conservative. And you can see here that there is efficacy shown. As a consequence, we give a yellow light. In other words, we approach these kinds of approaches with a variety of conservative management, physical therapy, shockwave, dry needling at times, and PRP. With respect to the surgical studies, after ACL reconstruction, showing better control with PRP, better healing at 6 months, we give a green light going forward. And again, this is our approaches. Yellow and green means we move forward. How about medial collateral ligament injuries, as you see here? This is a retrospective study, 31 patients. It's published in the Arab Journal of Sports Medicine. Ultrasound guided PRP injections and showed it was improvements with respect to PRP injected in MCL tears at 6 weeks after injury. If we look at further studies as a consequence, we give a green light in this regard. So when we have an athlete with an MCL injury, we feel comfortable making that recommendation. ACL injuries, common we see in athletic populations. And if you're looking in your respective communities, these are common injuries. We've seen biological approaches, and in this, Martha Murray and her colleagues have developed the BEAR, Bridge Enhanced ACL Repair. It's a way of repairing it and use a scaffold and whole blood. And they've compared 100 patients, 65 that had this technique and 35 that had the reconstruction. Re-injury rate of 14% in the BEAR group, 6% in the ACL reconstruction. For us as athletes, this is a major consideration that we have not yet solved. So we're not ready for prime time in this group. Also, when you look at this study that comes from Hospital for Special Surgery, you have a 33% revision rate to an ACL reconstruction doing repairs. So from our standpoint, for an athlete, we give this a red light going forward, but we are very interested in using biologically enhanced reconstructions using things like PRP and bone marrow aspirate in this population, but not for the repair, only for the reconstruction. And why? If you look at this study that comes from Chile, Santiago, in 2010 published, 50 patients with ACL reconstruction, 25 with PRP, and lo and behold, look what they found, 48% reduction in healing time, allowing the graft to heal better and quicker in maturing. Now, how it helps the whole situation, we check all those boxes, is really our next step. But it's encouraging, and as a consequence, we recommend using biological enhancements in ACL reconstructions, as we see, like in this study that comes out from India, BMAC injections seem to accelerate graft to bone healing in ACL reconstruction. We're always looking for a hedge, and in this case, we give a yellow light. Caution, we move forward, but it appears to be some benefit going forward. How about in this situation, meniscus repair? This is a great study coming from Ohio State, Dave Flanagan, Everhart, and his colleagues. And I really want to point out, when you use PRP in meniscus repair, this doesn't mean we're using PRP without a repair, surgical repair. It is with meniscus repair. They found the survivorship, as you can see here, in this amber line versus the blue, the green line. It is a very statistically different effect, p less than 0.008 when they use PRP. So PRP really helps with survivorship going forward. As a consequence, we truly recommend PRP for helping meniscus repair. It's one of the great major advances we've had in terms of orthobiologics and meniscus repair. As we go down, we want to really think about a great case situation in an athlete. Here we have a 25-year-old professional player. He's had ACL reconstruction on one side, is doing well, but the left knee in 2015 had a meniscus tear. Look what happens to him just 6 years later. You can see here, and in fact, there's narrowing of the joint space. And a professional player still playing, but he has some narrowing. The elevator is going down. And this represents a significant situation. Here's another player, a different team, had ACL reconstruction on this side. And again, still 25 years old, and we begin to see not significantly bone on bone, but a type 2 Kelgan-Lawrence decreasing joint space, and the same situation, the elevator is going down. So what do we do about this? How do we think about the concepts? How do we think about prevention and changing the progression in this disease modification? It starts with things like chondroprotection using glucosamine. And in this systematic review, we see from Mike Cicciotti from Philadelphia shows that glucosamine, chondroitin sulfate may protect cartilage and delay the progression. As a consequence, we give a green light in this situation. How about HA? HA is great for lubrication and maintaining the high hyaluronic acid. It also decreases the inflammatory response and protects cartilage degeneration. As a consequence, we give a green light here overall. In addition, when we look at some of the recommendations, some of the guidelines that we've seen show in the past that HA has no real effect. But in this most recent network meta-analysis, we find that when you look down here at the high molecular weight, separating low from high, that you get a significant, minimally clinically important improvement that is statistically real. That it's the high molecular weight, not necessarily the low, that make a difference. A key differentiation in understanding of the biologics. Now, we talk a little bit about PRP before, but how does PRP work? Let's look at it. We got Auger right here, PRP over here, MSCs over here. Look what happens. You have the summing and the proliferation of the MSCs once they get to the PRP. So PRP has a very significant direct effect on MSCs, proliferation, and summons them when they get there, and therefore has a positive effect on cartilage metabolism, regeneration, synovium, meniscus, and chondrocytes going forward. And that's why PRP is so successful going forward. And as a consequence, we give that green light going forward. But also, there's some other great information in terms of how PRP works going forward. We know PRP has a direct effect to stimulate cell proliferation of chondrocytes. It potentiates SOX9 transcription and elevates COL2A1 and ACAN expression. So people say, how does PRP work? proliferates, summons the MSCs, but it also targets the expression of some very important anabolic changes within cartilage that we see demonstrated here. On the clinical side, if we look at PRP versus placebo at 6 months, PRP versus steroid, the scatter plots, as you can see, favors PRP going forward. If we look at PRP versus HA, 9 studies over here, WOMAC at 6 months and 12 months. And once again, as you can see, it favors PRP going forward. If we look at other studies, level 2 systematic review, if we say PRP versus HA, it's superior in systematic review going forward. But we're not done there. A lot more questions. And one of the questions we need to answer is really the effect of what type of PRP do we use. In this study coming from Milan in the Rizzoli Institute, we find that low white cell PRP versus high, that there's absolutely no difference going forward. So at this point in this study, it shows that there's no difference. So we give a yellow light going forward in terms of our interpretation. If we look at PRP in OA, what is the exact critical dose? In this particular study, they conclude that you have to have 10 billion platelets is crucial for PRP for a long sustained chondroprotective effect. That's a very interesting point because we have to look further, use things like Hariba analyses to know exactly how many platelets. But I think this is a very important stage in our maturity in understanding exactly platelet populations and what kind of clinical effect that we have, especially with respect to the chondroprotective effect going forward. And the consequence, we give that the green light. And we're now at PRP 3.0 because we're looking for other ways, other adjuvants. And when we were comparing PRP to HA before, but now we think about PRP working synergistically with HA. And how does this work? It works by the HA induces the release of more growth factors from the granules, TGF, beta 1, and PDGF from the PRP. So again, we're getting more maturation in our mind in terms of understanding these concepts and techniques. As a consequence, this is something we now do in all our athletes. We synergize the PRP and the HA, we use them together. And once again, 7 studies in systematic review show that HA plus PRP is better than PRP or HA alone. And we give this a green light as we move forward. Now, you also see in this other systematic review coming from Chicago and Brian Cole's group, that they conclude that patients with the OA who were injected with both the PRP had greater improvement when compared to HA injections alone. So once again, we're seeing these combination systematic reviews showing superiority with respect to the individual therapies, much like any other medicine. Adjuvant medicines, when used in combinations, tend to work better than individual situations therapeutically. And we, therefore, again, give a green light to this kind of information. How about other things? How about we compare BMAC in terms of understanding how it can work overall and see the various changes going forward? Systematic review. The conclusion of the BMAC says it's effective in improving pain, but perhaps no clinical superiority in relationship to the other types of biological changes. And as a consequence, we see this 2-year prospective randomized trial that Adam Ans and his group did. And what they find at 24 months was that BMAC was not superior to PRP in and of itself. And therefore, we have to put that into perspective and understand that the two biologics are performing in a very similar fashion going forward. As a consequence, in terms of choosing one or the other, we give it a yellow light. We have to be cautious in understanding this and base our conclusions, not just by one study, but by all our literature going forward. And how about MFAT, or stromal vascular fragment? In this meta-analysis and systematic review, they concluded that they both resulted in symptomatic improvement, but maybe the stromal vascular fragment may be superior in terms of reduction of overall knee pain, but both were effective going forward. And again, it's another study. We're learning more. We're putting together a body of information and basing conclusions. And once again, we move forward with both interventions, hopefully learning more as we go forward. Exosomes, extremely exciting, and one of the next step frontier approaches. And again, we're learning more as we go. But when it comes to athletes, and especially with respect to the FDA making recommendations at this time of us not using exosomes, we recommend continued use of this in clinical trials and studies at this point in time. So we give this a red light going forward. How about with respect to amniotic suspension, allograft? Over 12 months in this randomized controlled trial for symptomatic, the same group of individuals with OA, the study I participated on, and we showed statistical efficacy in all of these situations. The problem that we have now is those same recommendations from last June from the FDA, again, against using amniotic fluid, and we've got to be cautious in our approaches because of their recommendations in the FDA specifically. How about when it comes to allogeneic stem cells? This study was done in 2000, published in 2014 by Tom Vangsness, and again, did not show significant efficacy. As a consequence, we say stem cells may not be ready for prime time. In fact, they may be inferior going forward. And as a consequence of, once again, the FDA guidelines, we give a red light with respect to athletes. But how about what's in the future? Here's a study published in 2019 by my good friend João Espargaro Mendes from Porto, Portugal, where they looked at culture expanded bone marrow derived MSCs and combined them, adjuvant, just like we spoke about earlier with HA and PRP, but combined those with PRP and found that the MSCs plus the PRP, as you can see in green, were the best at alleviating pain and reducing symptoms in this patient population. And I say that this is in yellow going forward overall. But unfortunately for those of us, United States, because the FDA, we cannot have culture expanded bone marrow derived stem cells. So we get a green light, and we look forward to hearing more information from our colleagues in Europe. Now, and we're going to end on this going forward. How about estrogens? And again, we can never forget our female athletes, our daughters, our wives involved in sports. And why? Because of this study. We can see this study was done. It was a 10-year population study done by Hussein Chicottini in Melbourne in 2014. And over a 10-year period, they followed 2,600 women. They found that if you had greater estradiol levels, there was a much lower incidence of total knee replacement and hip replacement. And the conclusion was that circulating sex hormones have a direct effect on osteoarthritis pathogenesis. And why? As you can see here, cartilage, the estrogen receptor, they have different isoforms, alpha and beta, 36, 46, 66. They're androgenic receptors, progesterone receptors, and they go up and down with menstrual cycle, pregnancy, menopause, ACL tear, and osteoarthritis. And when we look more closely at this in cow explants, and we hit those with a single load compression strain at 50%, 96 hours, all the cells die. But if we put estradiol in the medium, it reduces the cell death and releases GAD going forward. So maybe for the future, we have to develop a safer estradiol that impacts these receptors going forward, and especially in older female athletes. So we give a green light with respect to this going forward. Now, we're learning more and more, and this is a great book coming from David Sinclair, who's been working on the survival genes and understand these pathways the TOR, AMPK, and the sirtuin pathways, and develops a concept of hormesis of how we can protect our cells, our DNA going forward. As he says, that aging is a disease that is treatable. It's an ancient survival circuit of vitality genes that we could slow down or even reverse aging going forward. And these pathways exist in the chondrocyte as well. We could see here that the chondrocyte is here, and these same AMPK and SIRT3 pathways affect development and progression of osteoarthritis through a positive feedback loop. And simply stated, we could look even closer that the apple procyanidins, and they exist in apples, just like our moms always told us, an apple a day keeps the doctor away. But when you look at this one component, this one phytochemical, as you can see here, affects collagen 2A1 and MMP3s by reducing them statistically and significantly. We learned that we could affect with these biologics, just in an apple, we could affect these pathways going forward. As a consequence, green light here going forward. And also we learned the same thing, that 17 beta estradiol through this pathway, through the estrogen receptor, we turn on the SIRT1 messenger RNA, the SIRT and AMPK and mTOR pathway, and once again, we affect the viability and proliferation of chondrocytes. At the end of the day, we're talking about knees, we're talking about cartilage, we're talking about chondrocytes and preserving them and preventing them from breaking down, losing integrity, and getting osteoarthritis. So we're learning more about these novel pathways, and as a consequence, green light to think about this going forward. We just have to have better interventions moving forward. So we end on this. Here are the players in 22. We've given green lights to corticosteroids, glucosamine, HA, and PRP. Yellow light for cytokine modulation and some of these stem cell procedures. Again, that means we can move ahead, but we always need to be cautious. We need more research in these regards, but again, we be cautious. Exosomes are red because the FDA, with respect to alpha-2 methyl-globulin, we're very excited about this technology. We're going to move ahead with the yellow light. We're going to do better studies. We're going to look at comparative studies. Amniotic fluid, because of the FDA, we have to be cautious. Estrogens, again, green light in our approaches. And we give red to the M2 macrophages and WNT pathway inhibitors. There are ongoing clinical studies that are being done by Biosplice. We're very excited to see these pathways going forward. So, as I told you, we really wanted to discuss in the athlete how we're approaching them. What was fact, what's fiction, and what's fantasy? And in this population, our major goal is always about performance, prevention, and care. And as you can see, we've learned a lot of concepts. We're developing great techniques and technologies, and we're also learning when and how we recommend these, when to be cautious, when we need more information, and when not to recommend those to our athlete population. Thank you very much.
Excellent. Thank you, Dr. Mandelbaum. It looks like we do have a couple questions on the Q&A section, but I think some are having difficulty typing in. And so if you do have questions and you're not able to type them in, press the raise hand button and Sean will unmute you at the appropriate time and you can ask your questions live to Dr. Mandelbaum. So when you do press the raise your hand button, there will be a box that will pop up to unmute yourself. So look for that when it's your turn to ask a question. But first, I'll read a couple that have been typed in. The first one, Dr. Mandelbaum, is how soon after an orthoscopic knee or shoulder cleanup would you inject a biologic into the joint? No repair, just cleanup on a 50-plus-year-old ex-athlete. What would be your preference for biologic type?
Well, I use PRP fairly often in the knee intraoperatively. So for the surgeons, when you finish your arthroscopic procedure, you clean the knee out, you drain all the fluid out, and you just inject the PRP right there. I think that's a great way to do it and is a standard way that I approach that. And again, depending on the situation, I call that injection 1. I would come back with injection 2 and 3 at week 6 and 7. I also would use that in conjunction with HA, a high molecular weight HA, simply because of the synergies that we discussed earlier.
Perfect. Next question is, there are multiple PRP systems available in my clinic. Are PRP systems essentially generic, or are there some that you would avoid or focus on?
I think that the key, there's several principles that are really important. And again, we're talking about several different diagnoses. For the most part, when it comes to knee osteoarthritis, we want to get a fairly significant, as you saw from that study, 10 billion platelets are requested. So I think that we should become facile with how many platelets exist, how many billion platelets exist in your injection. Using the Hariba and other types of analyses will give you those types of metrics that are important. So which one you use respectively, I think you've got to ask the question is, what system gives you the right combination for that situation? For osteoarthritis, perhaps it's a lower white cell, more platelet. For a tendon problem, it's okay to have more platelets and more, even some more white cells in that situation. So I think it's not one thing for all situations. You've got to know a very specific and have a specific understanding of what you need to help the patient at that point in time.
Okay, perfect. Do you recommend PRP and BMAC on the same patient?
I generally don't. I mean, for me, they're two different interventions that we're trying to ascertain how and when they work. Most of the situations, I will tend to use PRP first. It's less invasive, it's less expensive. But then, like we do a lot of times, we'll go to the BMAC secondarily, and the BMAC can have efficacy. I view them as being two different interventions that I can't see myself doing 3 or 4 BMACs a year, but when it comes to PRP, it's more versatile. So it's not either or, it's really the combination you have to think about and when to use them in that capacity.
Perfect. I know your good buddy, Dr. DeLuigi, has this question. What has been your experience with reactive synovitis? What has been your experience with reactive synovitis, if any?
With respect, you mean after a biologic? I'm not sure I get the question at this point.
Okay, we'll have him.
Let me just talk hypothetically. If
Yeah.
we're talking about reactive synovitis after an HA, high molecular weight HA is, remember, we're differentiating HA products in recent years. It used to be HA was HA, and it's one of the consequences why we're having a hard time with a lot of the CPGs, the guidelines coming out in favor of HA, because they mixed it all up between low and high molecular weight. So there are a lot of people using a variety of high molecular, they were getting reactive synovitis from some of those that we're not getting now, that are more fermented and created in the lab. So when it comes to synovitis, we're not seeing that as frequently because it's more refined. With respect to PRP and seeing reactive synovitis, I'm not seeing that, to be honest, very, very infrequently. And I think the key is to make sure that we're doing a intra-articular injection. And I'm sure that in different clinicians feel either very comfortable with making sure the injection is in the joint. If you don't, and you're not using ultrasound, I recommend you do use ultrasound to verify that you clearly are getting the intervention into the joint accordingly.
It does look like Dr. DeLuigi wants to live chat with you, so I'm going to let him talk.
Okay.
Great, sorry, yeah. So
Hey, Art.
I typed it and I accidentally hit return as I was trying to type in the rest of that sentence. So there's another one that comes up with the rest of my sentence was when you were combining the HA with the PRP. And then are you doing them, would that have changed perhaps if you're doing them combination on the same day versus in sequence, if you're doing a PRP, then an HA or an HA, then a PRP, and how much time difference between, the interventions? So.
The way I've been doing it is we just numb up the area, the skin, with lidocaine, not putting the lidocaine in the joint because the lidocaine has a deleterious effect to the PRP. And then I have the needle goes into the joint, and I first put in the HA, and then the PRP goes in secondary to that. So I put them together mainly because we want to get more release from the respective granules, more growth factor. And we're very interested in that factor in and of itself. And I have not seen this reactive synovitis from doing that. With respect to doing a PRP injection 1 week and a HA injection the next week or vice versa, I've done that as well and have not seen reactive synovitis, but have seen the synergistic relationships as well.
Wonderful, thank you. Yeah, I know we've had a number of different patients who've I've treated and engaged in those conversations, and so many times it's oftentimes one can be billed to the insurance, the other does not. So we're trying to schedule it and coordinating it. I've asked other colleagues at Mayo how they've been doing it too and their experiences. So I just, with the opportunity here to ask you that both through the chat as well. Live, I greatly appreciate your input and background. So thank you.
I think as you've heard from Dr. DeLuigi, we're all trying to figure this out. We don't know, and that's why I say that we're evolving our approaches and we're learning. And we just at Cedars-Sinai finished our first 20 patients in our PRP analysis, where we're looking at proteins and cells after and correlating those with response and no response and other patient reported outcome details. And it's amazing to see the details and the differences between differentially expressed proteins and different cell clusters in the PRP. So the point of the matter is, over time, we're going to learn a lot more comprehensive information, and how each of these little details correlate with how the patients respond is even to be more significant. So this is now the era of detail that we're coming out in.
It looks like we have one more hand up. I apologize, there's no name on it, but it's 173340. I'm going to allow you to chat.
Hello. Hello.
We can see you, but we can't hear you. I'll ask another question while they may be figuring out their mic. Sean, keep it unmuted for them if they get figured out. I saw 10 billion platelets per injection. Any recommendation on total volume per PRP injection?
I think we've kind of settled on this 5-6 cc's. I think that's about the max that we get.
Recording.
So I think the answer to the question is somewhere between 5 and 6 cc's.
Okay, perfect. Sorry, we don't know the name. 173340. Can you hear us now, or you want to try again?
I can hear you. Can you hear me?
Yes, go
Yes.
ahead.
Great. Yeah, thanks. I was wondering, can you do PRP and amniotic tissue together, like you're saying PRP and the HA? Would that be synergistic as well?
I've never done it. I've never seen a study showing that. I'm not sure that I want to really cross a allogeneic procedure with an autogenous procedure at the same time. I don't even know what the effects on target gene expression would be. So I would caution people from doing that simply because it doesn't make sense to me. Mainly because we don't know all that's in the amniotic fluid, and we don't know the direct effects of target gene expression. So I would caution against the use of that, thinking that it could be synergistic.
Okay. Is your experience for the amniotic tissue better than the PRP or not necessarily?
You know, we did that randomized controlled trial that I told you about, showing efficacy from the injection, and it was better than placebo control. So we know it has efficacy. But again, you're asking with respect to mixing PRP, which is a totally different situation. And that's why I would caution against the synergy, because we have to develop. If you said to me in our research meetings, oh, we have a great idea, why don't we consider this? I would say, let's develop a proof of concept model and to find out what the mechanisms are. One of the things I want to emphasize in this talk is we have to know the details. We just can't be willy-nilly in our approaches. We have to have proof of concepts that lead to some type of a scientifically based level of evidence-based interpretation. That's why I want you to take away from this webinar that we need to be careful. We're clearly seeing good effects from the biologics, but I think we need to show care and concern and responsibility and accountability moving forward.
Okay, thank you. Thank you.
Just a couple more questions. It looks like, how does or can HA and PRP help prevent knee replacement in advanced knee OA?
Well, we know that in recent study that 26% of knee replacements are done prematurely. And we're trying at this time to reduce the incidence of knee replacement. For any of us, we all want to avoid knee replacement if possible. I'm the surgeon, I'm saying so we want to find out in the algorithm how we can manipulate the knee to improve pain, to reduce symptoms and improve function. And that's really the question at this time that everybody's asking. And there's been a study out of Italy looking at the decrease in the incidence in the national health system using PRP. They found a decreased incidence of total knee replacements with PRP. So I think that's the goal. From a population perspective, that's what we want to take. That 26% in conclusion was done prematurely, and how to improve that population and push out when knee replacement has to be done.
Perfect. Another simple question. Do you have a preferred HA if insurance is not a limiting factor? I think he's looking for a specific brand.
You know, I tend to, I don't want to get into a specific brand, but I think the key is to find one that has a molecular weight around, molecular weight normally of HA is around 2,000 kilodaltons. So I would have you select an HA product that is high, meaning about between 2,000 and 3,000 kilodaltons. That'll give you that ability. It's a high molecular weight approach.
Perfect. I think we have one more question here. What are the main differences between PRP and BMAC injections? I always hear that BMAC is always a better option if you have the resources to receive it. And you know, some of your lecture was maybe speaking contrary to that. So maybe you want to expand on that just a little bit, Dr. Mandelbaum?
I think both have efficacy. You know, both have efficacy as we've shown in that meta-analysis, which is great. I like to have many tools because, and I tell patients, this is a journey. You know, we may be using PRP in January and we may be using BMAC in June. and then PRP again next January. So I think we have to become facile with it all. This is a family of interventions, and they have different benefits, they have different costs, different degrees of invasiveness. So you have to develop an algorithm, and don't look at the patient as one and done. Look at it as a journey that what we're going to do here in January, what we're going to do in June, what we're going to need to do in next January. So for me, they're both efficacious. I'm excited about both of them, and I do both of them. So don't look at it like it's a competition. Look at it like we're going to manage the patient, and we're just going to vary what we do over time.
Perfect. Do you mind touching on this upcoming conference that Advanced Regenerative Medicine is having that you're co-chairing in February? Just maybe tell everyone the highlights of that.
Well, we're excited about this meeting next February 3rd to 5th, 2023 in Salt Lake City. At that point, we're going to have a great faculty. We're going to have some hands-on labs teaching everybody how to do PRP and bone marrow aspiration. You're going to get a chance to do some live patient demos at that time, and it's going to be a great opportunity to exchange, as we talked about today, concepts, technique, and technology. We welcome everybody to come.
Perfect. Thank you. And then our next educational topic will be here on October 24th. So please sign up for that as well. That's a complimentary webinar to just continue to expand our knowledge from experts all over the country. And those that would have a topic they would like to present on behalf of Regenerative Medicine Institute, please email Sean, and would love to explore these different topics. The goal here is just to provide more knowledge and further push the sound, compliant field of regenerative medicine. And also just want to thank our sponsor, Apex Biologics, for helping make this educational series possible. If you have questions about their complete resource for all orthobiologics, including BMC kits and PRP kits, reach out to them as well. But anyway, Dr. Mandelbaum, thank you again for your time. We really appreciate it. If there's other questions we didn't answer, please email them to Sean, and we can follow up accordingly. Thank you, everyone, for your time, and have a wonderful weekend.